Good afternoon. I hope everybody had a nice lunch because we'll be talking about food. I mean, drugs too, but food's really the way I see the world. All right. All these slides are already posted publicly. You're welcome to use them. They're public domain. You don't have to ask. I started doing this work in 2002. I was doing street outreach for a study, the second study ever done on OxyContin abuse, and that was in Washington County and Cumberland County. This is in the USM dorms. I was going to wear a bandana, but given how sharp Gordon always dresses, I thought he wouldn't appreciate it. So instead, I got this. This picture also breaks my heart because Tony, the one who's holding up the pamphlet on how to prevent overdoses, died from an overdose a few years later. So I come to this work, like many of us in this room, with a sense of grief. The main point that I want to bring out today is answering these two questions and encouraging you to think about how to answer these questions in your own circumstances. What's working and who's left behind? Just to set the big picture, and Ryan did a good job with some of this earlier today, but in the early 2000s, we had prescription opioids. There was a crackdown on pills and prescribers. We had an emergence of heroin. There was a lot of heroin busts and interdiction. We got fentanyl. Fentanyl got class-wide scheduling and other means. And what you'll hear about today is what the drug supply looks like now in real time, and it is a crazy mix of synthetic opioids and sedatives, which is a kind of cyclical consequence of the way we've done drug policy in this country for 50 years. And how are we doing after 50 years of the war on some drugs? Well, the good news, and this is what a lot of us, you've been hearing the celebration and kind of recognition of, so nationally overdose deaths are down 30%, about 29%, about 30% from the peak in June of 2023 compared to December of 2024. This is what it looks like graphically this is all drug overdose deaths, all causes, from 1979 to 2000, end of 2024. You can see 2024 was that blip, is that circle at the end. That 29% that we're talking about in the decline is this time period, June 23 to December 24. So that's good. But the same graph you can also interpret this way. There's been a fourfold increase in drug overdose deaths from 1999 to 2024. And that's heartbreaking. Cumulatively, that's 1.5 million people who have died of overdose since the beginning of the war on drugs. We need to do better, and I think we can. And the work that you've been hearing about today in this room is how we change a half century of failure and move to a more humane and compassionate response to what our society is facing. This is the bottom line. We are still losing way too many people we love. This is a time to reflect on what's worked, but this is not a time to let up. This is a time to continue the work that you've done and go forward even with more vigor and more resources. Here's another number, 1.4 million. 1.4 million is the number of kids who have lost a family member to a drug overdose death in the United States. That is a huge amount of intergenerational grief that is accumulating in our societies, and we don't do enough to acknowledge that and address it. I will be touching on this theme of intergenerationality later, so please keep this number in mind. This is what I struggle with as a scientist, doing this for 2 decades. How do I go to work every day with all this grief piling up? How do we make our work meaningful despite all this grief? And in this moment of overdose decline, when it feels like, yes, our work is making an impact, but also saying that overdose numbers are declining kind of weakens the first line of all our grant applications, right? And kind of putting that in context and seeing what else it is that we need to be doing. So let me introduce myself a little bit further. I work at the Opioid Data Lab, which is a collaboration between the University of North Carolina, Kentucky, and the University of Florida. I'll be upfront about my funding and disclosures, so you all know where I'm coming from. Our work is funded by foundations and nonprofits. We have funding from our state health department and our General Assembly. We have research funding from the U.S. Food and Drug Administration, and we conduct drug analysis as a fee-for-service, free or at cost. I'm also an uncompensated board member and co-founder of Remedy Alliance for the People, which is a nonprofit, and we provide naloxone free and at cost in bulk to harm reduction programs. I was just checking the numbers this morning. Since our inception in 2022, we have sent 163,000 doses of naloxone to the state of Maine. The way that our model works at Remedy is that we negotiate low-cost contracts with pharmaceutical manufacturers of naloxone, nasal, intramuscular, as well as emergency contraceptives. So I'm honored to do that work with my two co-founders, Maya Doe Simpkins and Eliza Wheeler, who's also on the board of Maine Access Points. All right, and I do not accept any industry funding. So our projects at the Opioid Data Lab fall into three categories: theory, practice, and lived experience. The theory projects deal with biostatistics, pharmacology, psychology of communication. The applied projects are looking at the research, at the practice of pharmacy, medicine, vital statistics, and harm reduction. So including how do we count overdoses. Our lived experience projects are the coolest by far, and these are field work. This is looking at drug checking and analysis. But what's really important about the lived experience projects is that we only answer questions that are brought up to us by community. And the thing that I want you to really take away is that we can get better questions that actually matter to people if we listen to what community is telling us they need to know. Our approach is different. We think of it not as research, but as science in service. All right, so here's one of the science and service projects. We all know that the drug supply changes rapidly, but we don't find out what's in drugs until it's too late, when people are either dead or they're arrested. There's no opportunity for prevention, there's no opportunity for recovery. To fix this, our lab on campus at UNC monitors street drugs as a public service. We do this with this kit that we get samples from harm reduction programs, drug user unions, health departments, clinics, hospitals, EMS from around the country, all right? We just need a tiny scoop of powder, less than a grain of rice, or even the empty bag, a swab of an empty bag, a piece of a pill, or a used cotton. Pretty easy. This is what it looks like in practice. This is Ainsley Bryce out in the Appalachian Mountains in North Carolina. The samples, importantly, are given to us voluntarily, and the tests are anonymous. We collect a little bit of data on the circumstances, if it was involved in an overdose, what the sensations were, color, things like that. And these are important because molecules don't tell human stories. Molecules don't say anything except to show that they're there. In order to really understand what's happening with health, we need this additional contextual information. Colors and smells and sensations are how people who use drugs understand what's in the drug supply. People who use drugs have been testing drugs on their own bodies forever. And what we're doing is providing context and science to help them make better decisions about what they put in their bodies. Amazingly, the packages arrive on our campus by FedEx, and we are in compliance with a lot of federal and state laws. I'm a state government employee. Believe me, we have a lot of people looking over our shoulders. When the packages arrive, we record the information. This is what our lab looks like. It looks way cleaner than it actually is somehow in this picture. We do some prep of the samples and load it onto a machine mass spec or GCMS. What's important is that we do untargeted search with atomic precision. So untargeted means if we figure out exactly what's in a drug substance, no matter what it is. This is unlike some clinical panels like you would use in the hospital, which has a panel of substances that are being looked for. So since we started about 3 years ago, we've now analyzed 14,000 samples from 41 states, including from Maine. And we serve 174 harm reduction programs around the country, including a handful here. So how many drug substances can you name off the top of your head? Usually like a dozen, 2 dozen? Well, we've identified 438 unique substances in the drug supply. That's a lot to keep track of. And so most people don't have any idea what is actually going into their bodies. And this is a problem. So I'm just going to give you like a snapshot of what this looks like in practice. So these are the new detections that we had in May. So 9 new substances. We usually see about 135 substances in the drug supply in a given month. And so of these 9 substances, I'll take you a quick chemical tour here. So the first one, methylclonazepam, is a more potent benzodiazepine that causes very heavy sedation, not one that we like. You'll see estradiol on there. So one of the things that we've been seeing increasingly is as gender-affirming care is rolled back, there is DIY hormones being sold, manufactured, imported, and distributed for people who have lost access to gender-affirming care. So we see those showing up in the drug supply. You can also notice we see mifepristone, which is one of the medications used in abortions. As abortion access is curtailed in the United States, what we see is DIY mifepristone being made, sold, imported in unregulated markets, and a black market for them is emerging. So this is just a snapshot of what we kind of get in every day. Oh, and the last one I'll point out is one that's very hard to pronounce. It's tirzepatide. It's the third one down. But that's a GLP-1 medication. You know, like you've heard of Wegovy or Ozempic, like the weight loss drugs that are super popular. Guess what? Expensive medications that are in high demand are also showing up in the drug supply because people are making their own, importing them themselves, and this is kind of what naturally is happening with substances in the United States. So every month is a new adventure. Most importantly, we give the results back to the people who provided the samples. And we use that with the QR code, the results. I'm happy to announce that as of this week, our results are live, real time. So the moment they come off the machine, are interpreted, they go out on the website. So a little tech brag there, but that took a lot of work. But this is really important, because what this fundamentally does is changes the question of how you do dissemination of public health data, because the people who need to know most are the ones we're informing first, right? So then the question comes after that, how do we let public health authorities and the broader community know? And that's what I'm here to do today. But everything all the inference I give you now, we've already provided day of to people who actually are the ones who are exposed to that substance. At the core of what we're trying to do is increase people's autonomy. We want to help people make better decisions about what to put in their bodies. And sometimes that decision is not to put it in their bodies. Sometimes it is to use less of it. And sometimes it is to use it not in combination with other things that may cause other problems. The coolest part of all this is that because we provide this as a service without a lot of expectations from people and not as a research study, the questions that people are using to answer, the reason that people are using the kits to answer, these questions are way cooler, way more important than anything that we as science nerds could have come up with. So here are some examples. Is there fentanyl in the black tar heroin? There was a drug user union in Texas who was having a big debate of whether there was fentanyl in the black tar heroin. And so they systematically went and sampled in 4 or 5 different cities, and sent us the samples. We didn't know which ones were from which purchaser or whatever, and we told them, and it turns out, yes, there was fentanyl in the black tar, but only so in Texas they have land-based distribution of fentanyl and sea-based distribution of fentanyl. One of those routes is the one where the fentanyl was showing up with the black tar, and the other one was not contaminated. So just nuance like that allows people to make safer and better decisions about their lives. I'll talk about nitazines later, but here's some of the other questions. So we get physicians or hospitals who have patients whose withdrawal symptoms or other physiological harm does not align with any sort of known medical drug condition. And if you have 438 substances in the drug supply, it's Russian roulette. You don't exactly know what that patient has got. So we get samples from hospitals being like, can you help us figure out what this patient took? And the question we ask them is, did the patient consent to having this drug sample sent to us? And if they did, then we'll test it and get them results back that same day so that that patient can be treated with better care in the moment. Fentanyl test strips and other test strips are very common these days, but I will tell you, some of them suck. The quality of them varies a lot, but manufacturer to manufacturer, and even within a manufacturer, batch to batch, the actual antibodies used in those tests can change, and they won't tell you. So when you're using these test strips in community and people are saying this was really supposed to have fentanyl in it and it doesn't, or there's discordances like that, it's important to work with a lab like ours to figure out what the accuracy of those test strips are in your community's drug supply. Another fascinating one was, can black lights identify xylazine and fentanyl? This was a drug user union in Nevada, and they had a street rumor going around and they sent us a picture of all these piles of dope that were fluorescing under black lights. And so black lights, if you've been to a party and there's a gin and tonic and your gin and tonic is glowing, well, A, you're probably over 45 years old, but B, that's what black light, that's what the thought was, is that you can identify what's in the dope. So they didn't tell us which samples were which colors or what. They sent us some normal samples. We tested it, told them what was in those samples, and they were like, thank you so much. Now we have our answer, and we've been able to figure out how to deal with this street meth and get rid of the misinformation. I was like, cool, so what's the answer? And they were like, click. And so I don't actually know. I don't know the answer to this question, because what was happening in central Nevada at that point in time has zero relevance to my staff, and it has really no relevance to anybody else's drug supply either. This is a question, and this was knowledge that we helped create, but this information we helped create, the real knowledge remained in the community where it belonged, because those are the people who can make the decisions that save lives on the ground. We don't need to know that. We also get very heavy questions. What killed my husband? We get samples from widows. The medico-legal process for autopsies in North Carolina takes about 8 months. And even though our medical examiner does a lot to work with families to help them understand during that process, sometimes widows will come to us and say, my husband only smoked meth. Why are they saying he died of a fentanyl overdose? And we will test those pipes. It's hard work. And it's very sad. But we do, so kind of putting the science nerd hat back on, we do a lot of statistics and hidden patterns, and I'll show you some of the data right now, or in the next few minutes. One of the other things we get to do being at a big university is that we have a lot of colleagues who are very smart in pharmacology, cheminformatics, and animal models, and so when we detect new substances that have never been tested in humans before, we kick it over to our colleagues in other departments, and they can rapidly characterize what receptors this new molecule binds to, and kind of create a chemical profile. Doing this, when xylazine emerged, which you heard Governor Mills talk about, we were able to discover that the science on xylazine was 50, 60, 70 years old, and it turns out xylazine actually is an opioid, even though that's not what was known pharmacologically kind of previous to that. And it's a special kind of opioid called a kappa opioid. So these are the kinds of discoveries we can make by working with community, getting those samples, and using our scientific resources in service to community. This is a quote from another drug user union in Scotland talking about the unregulated drug supply. The drug supply right now is really bonkers, and I'm going to give you, rapid fire, the 5 ways that I use to make sense of the illicit drug supply, all right? Here's the key insight. Trends in consumer goods explain much of what happens in the illicit drug supply. All right? So here's where we're going to start talking about food again. Number one, everything is polysubstance, except for meth and crack. Meth and crack in the US right now are very pure. Almost every, and ketamine too. But for most of the other street drugs, especially the opioids, it's always polysubstance. We almost never see fentanyl by itself. So how bad can it get? Let's see. So this is an energy drink you can buy at, I think, literally across the street from here at Walmart. I don't know, wouldn't suggest you'd get it, but here's the ingredients in it. What we see in the consumer goods space is the blending of natural products with synthetic products, of flavorings and preservatives, kind of a very big mix of what is just, you look at that bottle and you're like, okay, 0 sugar, it's, seltzer water with caffeine and some flavors, right? But here's all that's really in it. Some of it, is questionable. All right. Here's a drug sample from Durham, North Carolina from February of this year. There was Benadryl, Tylenol. There was a weak opioid that's kind of like kratom, called tianeptine, but very specific to North Carolina. We have found 3 different medications for schizophrenia, nausea, and an anxiolytic. We found local anesthetics like lidocaine, as well as central anesthetics like medetomidine. There was just a little trace of fentanyl, a little trace of cocaine, and we found some cuts in there too. So when people say that they're taking fentanyl, this is maybe what they were actually taking. So when buprenorphine inductions become difficult because it's not good enough, it's oftentimes because people have been exposed chronically to all these other substances that are contributing to an atypical form of withdrawal. Are we scared yet? Okay. Number 2 way that I understand the drug supply is counterfeits. This is one of my favorite studies ever done. I like to eat fish. Fish is a great, it's often on my plate. So this organization went and sampled seafood from grocery stores and restaurants. And guess what they found? 50% of what's sold as sea bass and snapper is not actually sea bass and snapper. It's some other kind of fish. All right, you say flaky, white, generic looking fish. I get how that can be mixed up. But lobster? How do you mislabel a lobster? Is that a crawfish, crawdad? No. How do you take something as distinctive as a lobster and make it unrecognizable is by repackaging it in something that it's not expected, or repackaging it into a different form, like lobster ravioli. And that's where the counterfeit lobster was showing up. Similarly, you take fentanyl and repackage it in a Xanax bar, and you get something as distinctive as fentanyl showing up somewhere where people don't expect it. The quality of counterfeits in the United States has increased dramatically, at least in terms of the visual ability to identify them. So that's number 2. Number 3 is adulterants, unexpected harmful additions. And I'm sorry to do this to y'all, but did you know your chocolate, especially the dark chocolate, is loaded with cadmium and lead? We talk about things that are bad for kids' brains, like drugs, but also cadmium and lead is also not something that, I hope there isn't like a festival where we give kids a lot of chocolate every year in October, right? Right. So what's amazing with this study is that if it says free trade and organic on it, guess what? It has more lead and cadmium than just like the plain milk chocolate cheap bars. So if this is happening in the regulated food supply, why are we surprised when the same things happen in the unregulated drug supply? It's the same societal trend. So here's an example of that. Acetamiprid is an insecticide. An insecticide is not a technical scientific term. Insecticide is a marketing term that the chemical industry came up with that actually describes a whole host of different chemicals, all right? So I know that bug spray and dope or insecticide and dope is kind of a trope, right? It's something that doesn't surprise us. We've all heard rumors of this happening. But what we really should be asking is what kind of insecticide was it? Because each of these chemicals has different profiles and different ways that they affect the body. If you're treating a patient in an emergency room who you suspect was exposed to this, you need to know exactly what kind of organophosphate or whatever kind of insecticide it is, because some of the cures for some of those intoxications and poisonings will exacerbate poisonings from some of the other insecticides. So we need to know this. At the same time, I've made a point that the drug supply is becoming adulterated with all these contaminants, but sometimes these contaminants also disappear. So acetamiprid showed up in a handful of samples in Washington State and in New Mexico last year, and in July and August of last year, and we were like, let's see what's happening here. So we put it on our watch list, and lo and behold, it disappeared from the drug supply after about 6 months. And so it's something that the drug supply is something that changes. It doesn't always get incrementally worse. It gets worse in different ways. Number 4, variants. Okay, so this is another over-the-counter thing that you can get. It's supposed to help you sleep. The 3 main ingredients that it says is GABA, 5-HTP, and melatonin. I promise this is the only molecule I will show you or slide with molecules because I can't make sense of them sometimes. But what I do want you to see is this is the molecule GABA that is supposed to help you sleep, all right? Pay attention to the H2N part. If you change that H2N part to a OH instead, you get GHB, which is gamma hydroxybutyrate, which is a Schedule I drug, also known as roofies. Right? So when I say we analyze street drugs with atomic precision, this is why we have to go down to the atomic level, because these small atomic changes have huge implications on people's actual experience with these drugs. So you heard, it was amazing to hear Governor Mills talk about xylazine. And I'm here to tell you that xylazine is now being replaced in the drug supply by another drug called dexmedetomidine. And it's a sister molecule, just a couple of atoms different. And since last June, we've seen, especially on the east coast of the United States, medetomidine replacing xylazine in the fentanyl supply. So our hypothesis is that xylazine so they're both in the same class of molecules called alpha-2 adrenergic agonists, basically sedatives. Medetomidine is a really important medication that's used in hospitals. It's called Precedex. Babies on ventilators, this is what you give them in the NICU for them to be sedated and have that machine breathe for them. So this is a really important medicine. It's also used in veterinary practice. So unlike xylazine, medetomidine is not a kappa opioid. And so we think the skin wounds from xylazine are rarely mediated through the kappa opioid system because there's a lot of kappa opioid receptors in your skin. And our colleagues who are at student service programs are confirming, in places like Pittsburgh, where medetomidine has replaced xylazine in the drug supply, they're seeing less fresh wounds from people who are using it. It's still being mixed in with the fentanyl, but the sedation for medetomidine is much more intense than with xylazine. What this has meant is that some of the drop-in centers have had to have new spaces for people to just sleep and relax. People are just completely conked out. They're breathing, and their breathing is monitored, but this takes a lot longer to wear off than xylazine does. So this is something to be aware of, and this is something that is going to start showing up in the drug supply here. The second thing I need you to remember about this is the withdrawal from medetomidine is even worse than withdrawal from xylazine with chronic exposure. And what this means is an agitation and anxiety that it has an onset after the fentanyl withdrawal has passed, about 2 weeks late, 10 days to 2 weeks later. There's another wave of withdrawal that becomes really hard to manage. So be careful with that. Number 5 is quantity. All right, so y'all know what Fireball is, right? What's the difference between these? Can you tell? It's hard to tell, right? One says whiskey and the other one doesn't. So in North Carolina, we can buy the whiskey version at a liquor store and the non-whiskey version in a gas station, okay? What's the amount of alcohol difference? It's almost double, right? So it's nearly identical looking and nearly double. The same thing happens with the street drug supply. These are data from Vancouver, British Columbia. And so they were looking at the concentration of fentanyl in bags of dope over time. And what they found was that fentanyl concentration doesn't just go up, it goes up and goes down, and goes up and goes down. It fluctuates. And it fluctuates in about the same band of doubling in potency over time. Overdoses increase when things go up or when things go down. Obviously, when they go up, people aren't expecting that high amount. Overdoses also increase when the potency goes down because people don't get enough to stave off withdrawal or feel an effect and take extra. So any fluctuations in the quantity per bag is going to have immediate ramifications on overdose risk. The other thing I want you to be aware of is nitazines. So this is a new class of synthetic opioids, which are already in the US. We've tested 150 or so samples from 14 states, and the two most common, protonitazine and metanitazine, are about the same potency as fentanyl, but nitazines are much harder to detect. I'm sorry, it's very hard to spell. But our colleagues in Ireland, for example, have had to deal with nitazines for longer. And in about half the overdose deaths in Ireland, there's no known substance that was involved because nitazines are super hard to detect in postmortem toxicology. So we expect with fentanyl, like fentanyl precursor and fentanyl legislation, cracking down on fentanyl distribution, nitazines would have been the next thing we expect to show up. We're particularly worried about some of the ones at the bottom, etodesnitazine, isotonitazine, because these are much, 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 much more potent than fentanyl and more potent than carfentanil and very hard to detect. So this would be a friggin' nightmare if this is what the US drug supply became after fentanyl. But July is an inflection point in this story with nitazines because of an agreement that the Chinese government made about a year ago that took effect on July 1st of this year. The manufacture of nitazines and all the associated nitazine analogs has been supposed to have been shut down in China. And so we are expecting to see disturbances in the nitazine market and consequently the fentanyl market in the US this month. And we haven't quite seen it happen yet, but it's coming. So stay tuned. We're not sure what's going to happen with this. So to recap then, the 5 ways I make sense of the unregulated drug supply is through polysubstance, counterfeits, adulterants, variants, and quantity. All right, so let me challenge some of our assumptions let me shift gears here. As we think about kind of how we take what's in the street drug supply and put it in the context of overdose deaths and what's happening right now with overdose declines, there's kind of this bridge in between. In order for us to really understand what's happening with overdose numbers, we need to go back and question some of our assumptions. And in doing so, I have found a few paradoxes that I didn't know of before that have really changed my view of how I think about interpreting the declines in overdose data. So this is a really basic question. What is your 1-year risk of overdose death if you continue to use unregulated street fentanyl? It's about 1%. That number is either really high or really low, depending on where you sit, but it's about 10 out of 1,000 people. How do we cut that number down? How do we make it so people are less likely to die of an overdose? The most effective way we have is methadone. The number cuts down to 6 out of 10,000. And that's a big improvement. But it's not zero, because people will sometimes continue to use, and methadone has its own host of pharmacological issues, right? But it is the most effective medication we have. Abstinence-based therapy, residential, actually increases the risk of overdose death in 1 year overall. The takeaway is that depending on the type of abstinence-only treatment that is being offered, it may be safer to actually continue drug use if the only thing we are looking at is overdose risk. But we're not, right? And I think this is the key point that I'm trying to make here, is that although we talk about overdose as like the most important thing, that the metric we're all fixated on, there are a lot of other harms associated with problematic drug use with the unregulated drug supply. And what some of the treatment programs are able to do, even if they don't reduce overdose risk, they may be able to help in other ways. But these are decisions, and this is information that should be presented to people who use drugs so they can make better decisions for themselves as to which type of treatment they would like to make, which type of treatment they would like to go into. What about prescription opioids? That's kind of how we started this whole conversation. What's the 1-year risk if you're a pain patient of dying from a drug overdose? Where does that fit on this, right? It's over here. It's 0.2 out of 1,000. So what was a huge problem in the early 2000s pales in comparison to where we are now. Another metric that surprised me, and this is a study we did in Kentucky, is this is the number, 1,429 is the average number of days from the end of a last opioid prescription and someone dying from an overdose from that prescription. That's like 4 years. So when we think about patients being abruptly discontinued and the way that chronic pain patients have been left behind in a lot of the opioid abatement work, it's important to remember that there is time to help people who have chronic pain conditions. There is time for us to do prevention and to reach out and help. We have years, but we should not be throwing away these people's lives. Another paradox that has challenged the way I think about drugs in America was this study, and it's called the drug bust paradox, and this was done in Indianapolis. And what they found was that within a 6-minute walk of every drug bust that was done in Indianapolis, the number of opioid overdose deaths doubled and stayed elevated for 3 weeks. So this is an urban environment. And this kind of blew my mind because at the same time, our colleagues who are EMS and paramedics, people who work directly with on the front lines with people who use drugs, are like, yeah, we already know this. Like, great, like nice that academia is finally catching up, because people, when one dealer is busted, the supply gets contaminated with other more unstable sources, and this is like a well-known phenomenon. The study was replicated in San Francisco. They found similar results. Within 100 meters of every drug bust, there was a 74% increase in overdoses the day after the drug seizure. So how do we work between public health and public safety to address this? If you ask cops, they're not going to stop taking drugs off the street or arresting people. But when there is a drug bust, could we not be working with the cops to flood that zone, flood that area with additional resources? Why aren't public health folks going out the moment that the package is secured and the evidence is taken care of, or whatever other procedural things needs to be done? There is time to do better. There is time to go and proactively prevent this unintended but actually predictable consequence of the way we do law enforcement in the United States. This is still the bottom line, and it bears repeating. We're still losing too many people we love. A lot of people are trying a lot of different things. And I'm going to start talking now about the decline in overdose, but I want you to remember that this is really the point of what we're trying to figure out, is how to stop losing people. Right now we hear from official sources in the media and everything that overdoses are going down, down, down. So as a scientific researcher, the first place I look for new information is, of course, Instagram. But we also hear from a lot of people that overdoses are going up again a little bit. In maybe non-fatal overdoses. And so I think this kind of really conveys that we're going to be in an up and down cycle for a while, but the overall trend is going to continue to decline. So in terms of now that we're thinking about why we might have overdose declines, one of the key things for us to pin in our heads is, when did overdoses actually peak in the United States? If they peaked all at the same time in different states, we would think like, okay, maybe this is all because of a change in drug supply. If they started peaking at different time over different states, then something more complex is happening. And that's actually the case. So between 2021 and 2024, every state in the United States has now peaked and is in decline with overdose deaths. And Maine was kind of in the 2023, late 2022 is when the peak happened here. And so you can see there's somewhat of a little bit east to west pattern in the declines, but the important thing here is that the US experienced a gradual decline in overdose deaths over 3 years, and that this decline started at different times throughout the country. So then that brings me to the question of, how much does geography matter? Well, drugs don't sweep across the continent like weather fronts. Instead, it's more like skipping stones on the surface of a pond. And what we see with the drug supply is drugs moving in that pattern. So here's an example. So so these are 3 cities. They're Wilmington, Delaware, Baltimore, Maryland, and Washington, D.C. They're separated by 100 miles. It takes 2 hours on a good day, probably 20 on a bad day, to drive between these cities. I want to show you each state's overdose numbers from 2020 to 25. So this is what Maryland looks like. So the gray bar in the middle is their average during this period. Red is higher than average, blue is lower than average. 219 is the number of overdose deaths per month in that state. So what we see is overdose deaths peaked in 2021, 22 in Maryland, and then declined, okay? And they've seen a very steep decline in 2024, 25. Here's what Delaware looks like, literally next door, right? Their peak was actually 2 or 3 years after Maryland's peak, but they too have been seeing a decline. And here's Washington, D.C. So their peak was even later than Delaware's, but they still haven't had as much of a reduction as the other 2 places. So these 3 spots, so close together, and whose drug supply you'd think would be interconnected, actually have really different overdose epidemics. So that brings us to like the shape of overdose declines. So this is here's the data from Maine. The purple line, you can ignore the blue, but the purple line is kind of your rolling average. And you can see Maine has had this, you all peaked in about late 2022, 23, and have been on a steady decline since then. The orange is kind of the monthly noise in overdose deaths, okay? So Maine has what I call an A-shape overdose recovery curve. And so these are the other states that have these droopy mustache-looking A-shaped recoveries. So red is higher than average, blue lower than average, and most of these states are now in decline. So one peak up and down, all right? What is interesting, though, is that there's a lot of states that have M-shaped recoveries, where overdoses went up, came down, and then went up again, and then came down. So how do we explain this? Is this different populations within the same state? Is it different demographics, different cities within the same state? When we talk about why overdoses are declining, these are the questions we need to be asking. I'm going to skip Arizona example and move on to generational effects. So I talked about how there was 1.6 million overdose. No, I'll come back to that. So one of the factors that we have been seeing as a pattern in overdose deaths in the decline in overdose deaths is that overdose deaths are getting older on average, okay? So here's data from Kentucky, and I'll just make this a little bit more clear. Overdose deaths among those aged 25 to 34 and 35 to 44 are on the decline, whereas the folks who are a little bit older, 45 to 74, are the ones who are making up a higher proportion of overdose deaths within the context of the overall numbers declining. So we've been working with Marcy Sorg here at the University of Maine, who is an awesome colleague and one of the people who's been doing this research for the longest in the entire country, and just a pleasure to work with. I hope you're here, Marcy. But she's one of the first to point this out in the country, and the reports that her office produces every month are really amazing in terms of detail. And what you can see within the data here in Maine, if you take this age group, 35 to 44, they make up about 12% of your population, but they make up almost 30% of the overdose deaths in 2024, in calendar year 2024. This year, that number has gone up to 35%. And in the most recent month of data, May, that's up to 42%. So we talk a lot about kids, we've heard a lot about primary prevention, but what is now happening is an aging of our populations at highest risk of an overdose. And conversely, the number of overdose deaths among younger generations is at an all-time low. And so we wanted to see if these trends that we've observed in Kentucky and Maine would hold on a national level. And so I'm going to show you a graph in just a minute, but I drew this because I find it easier to look at this. And here's what I think is happening with the demographics right now. We have an aging out. So baby boomers were the primary folks who are dying of prescription opioid overdoses in the 2000s, and they're now dying of other causes, stopping use, going on to have different lives. In between, there's less risky use, and so the dark is, let's say, 2023 or 2022, and then the light is 2024. And then the third thing is that we have fewer kids who are, and young adults who are initiating opioid use, okay? So I think this is the dynamic that's gonna is happening, and I'm gonna now show you the data that this is based on. So here, we're gonna look at the same kind of concept of where the overdose declines came from between 2022 and 2024. So you can see the purple is 2024. There's been this 30% overall decline, but this decline has affected, so 70% of overdose deaths are now happening in Gen X and millennials. Is that who you are targeting your prevention efforts to? If not, we need to think harder. We need to do better. What we are seeing simultaneously is Gen Z has reduced their opioid overdose risk a lot and are using more cannabis, more psychedelics, and a lot of other, and ketamine as well. So across the entire lifespan, almost every age group, every age has shown a decline in between 2022 and 24, with one exception, and this is an important exception because this is something we need to pay attention and do something about. This is kids born between 2005 and 2011 are the only age bubble that actually overdoses increased between 22 and 24, okay? And why would that possibly be? Kids who were born between 05 and 11 were in middle school and early high school during the COVID disruption, okay? These kids are going in the wrong direction in terms of overdose numbers when the rest of the lifespan is going down. We need to do better by these kids. I'll skip this for now. In closing, I wanna say we've talked about the drug supply, we've talked about the demographics. I think these are two of the big reasons overdoses are going down. The third part is the invisible work. And I want to give you two examples. So in St. Louis, Missouri, they have done an incredible job with their naloxone distribution. They reduced overdose deaths by 23%. But if you look down to the last line here, Black residents in St. Louis, their overdose deaths decreased by almost 49% during that same time period. So what is happening here? What they're doing differently in St. Louis is making sure their minority communities are at the table and are driving the naloxone distribution. Here's another example, Lake Charles in Louisiana. They saw an increase in overdoses in their hospital emergency room, and they implemented a really innovative and low barrier buprenorphine treatment system right in the hospital, similar to what we heard about here. I want you to look at these faces, and what do we see? We see relief. We see yes, something is working. I'm just going to point out the obvious. Look at the gender balance here, right? Look at the gender balance in this room. One of the things, if we have a narrative that the only way to solve the drug problem in America is through guns and interdiction and borders, this is not surprising for a society that chronically undervalues the contribution of women. A lot of the frontline work that is being done by women, and they're not given credit for the role that they have played in this societal generational decline in overdose. So we've talked about what's working, who's left behind. We've had amazing representation from Indigenous communities. I recommend listening to and following Philomena Quebec of the Bad River Ojibwe people, who has compiled amazing reports on describing substance use patterns in Native American communities. So, in summary, I think the reasons for overdose reductions are threefold. One is that there's been a change in the drug supply. Things like xylazine and medetomidine are reducing how much fentanyl people use and how often they use. Number two, that there's been a demographic shift in the people who are dying of overdose. Fewer initiates, people aging out, and less risk in middle age. And number three are behaviors. So behaviors at the individual level. People who use drugs are learning how to keep themselves safe, and naloxone is a really important part of that. Communities are learning how to keep their own communities safe. Access to treatment and all the recovery coaching, all the peer work, all of this work that everybody in this room is doing day in and day out, this is what is making the difference. Public health is working. Use your settlement funds wisely. Be critical, because not all interventions are created equal. Ask who's left behind. Get local information. Trust people who use drugs to tell you what they need and what's happening on the street. It's time to think about other drug-related harms, not just overdose. Hepatitis, endocarditis, skin wounds, these things are still happening and need to be addressed. And finally, properly resource your medical examiner system. This is our team. We have a newsletter. We'd be delighted if you all signed up. And thanks for having me.